worst ECG and why?
So either PCO2 कितने 40 or
40.
See, first one I think because
This one is it. So let's put it this way that worst ECG and good ECG. So who says worst? First one is worst. Niharika. Okay, Amit. Then
This
you cannot say no to you say yes or one of them you can say. I am asking you simple question. Who is saying that this is worse? The rest are all saying this is good. Everybody is saying this is good. Quickly, come on, you have to answer somewhere.
so
Yes, say.
at least that is better because we can.
This is better. So no, I'm not asking you why. You said this is better, right? So Vidya says this is better.
Second is not good.
You said second is not good. So she's not good. You are saying only Supriya is saying not good. Nikhil second Nikhil not good.
First is not.
Shane
Aishwarya.
first is not good. Sachin
second
is not good.
First.
Okay, so now this is a group that says first is not good. Okay, so what I have to do is you all come to one side first. जो भी first group है, come here. इधर आ जाओ, first वाला group, and you all discuss among yourselves and put some points as to why you say that is not good, and you also said it is not good. So you come here.
This one I said that is better and this one is bad.
This one is better, na?
No. Yeah, मतलब that one is worse. Second.
This one is worse.
Yeah.
So you all are Sachin. You said this one is come this side.
second one.
You say okay. So come here and tell me why. You all discuss among yourself and put up the points on the board. Okay. I will give you 5 minutes exactly. 5 minutes सोचो करो. 5 minutes discuss करो.
वो वैल्यूज लिखो ना मेरे को वैल्यूज ही नहीं पता थी मैं तुक्का मारा
Discuss करो.
उसमें वैल्यूज क्या क्या PCO2 कितना
Anyone wants to change, you can change now also. You all four are sure that you all four are saying that this is worse, right? Supriya, Nikhil, Sachin, and Vidya. Whereas you all are saying that this is worse. So Niharika, Arshad, Amit, and Aishwarya. ठीक है.
So PCO2
So you all ready with your answers? You all ready with your answers? You all can move if you want. You can move also. You can go to the other side. You can go to the other side if you want.
So वैल्यूज एक बार वैल्यूज बताएंगे सर
वापस लिखा है वैल्यूज उधर.
तो PCO2 कौन
ये हर टाइम ऐसे लिखते हैं. जब भी हम एग्जाम में ऐसे लिखते हैं, कभी भी ऐसे लिखते हैं, तो उसको अज्यूम्ड होता है कि सेकंड वैल्यू इज PCO2. रिमेंबर दिस.
अच्छा.
It's always assumed that the second value is PCO2, the third value is PO2, and fourth value is bicarbonate. It is always assumed like that.
Yes.
Okay. Second value is PCO2. Sachin, if you feel that you want to move, you can go to that side. So you want to go to that side? To go to that side, discuss. You don't waste time. I'm giving you 5 minutes. I'm putting the timer. You want to move to that side? No. Okay.
Backup is 23. But PCO2 is elevated 41. तो ये respiratory acid है. But normally 40 रहता ही है. तो ये good है. तो versus है. 18 of the metabolic acids of the composition.
Compensate कर रहा है.
हो गया? So what you're going to do is now they're going to put their reasons, or you're going to put the reasons as to why you feel that one is worse. Okay, here put your reasons. You all can write. You all can contribute and write. You all can, all of you all can discuss and write. Discuss and write.
Here.
So so you can hear Vidya what she's saying. Okay.
Normally what happens if the CO2 is rising or decreasing, the inverse, this is our normal equation. So here in this case there is compensation of that's
That is
why
good,
pH
no?
is maintained.
So it is good, no? You said it is worse. Why is it worse?
So because the metabolic component here.
So why are you saying it's worse then? You are saying it's compensating well.
No sir, that's
You just now said it is compensating. I heard that. So did I hear something different?
normally it is compensation.
Okay.
But
Here it's compensating.
no sir.
It's complete normal, no? And what is wrong here? It's a normal EVG. It's fully compensated. Normal EVG, no compensation only. This is a normal EVG.
So actually CO2, it is around 40. So basically patient pH is 7.4.
So first of all, so you have said that you have said something about this equation. Okay, go ahead. Now what do you want to say? You want to add something to this? So go to the board
So
and write it
patient
down.
is
Write it
trying
down.
to
You write it down. Whatever you want to write, you write it down. Whatever you feel is worse, your group you contribute to saying why this is bad.
Is 40. So patient is trying to like it is chronically patient is asthmatic.
40.
It's
So,
normal.
sir,
Normal.
So
she is trying to maintain normal.
No, backup is also normal.
Everything is normal.
Nahi.
If it
We are not able to
if it is
explain, so
trying to
patient
compensate,
We had one patient.
if it is a compensation,
that pH was deranged, na?
No,
No, pH also
नहीं, इसका 30, it was 30,
7.36
but उसका बाइका
ठीक है, इसको कर दे 7.2 कर दे उसको.
हाँ, अगर pH का होगा फिर
हाँ, इसको भी 7.2 कर दे. अब
So
सेम कर दिया मैंने दोनों.
this is basically
Same I gave you.
This patient will be more serious if we
Because
have a
he's-
bronchial asthmatic patient with PCO2 maintaining towards normal range with the
So that's why she says PCO2 is normal. That's why it's a problem. That's what you're trying to tell.
Yes.
But anything more you want to add, Nikhil? You are done with your court case. Next.
So here,
सबूतों के साथ ही बदल
so here the PCO2 and bicarb are less, and pH is 7.2. That means patient is compensating. That means patient is struggling more.
hyperventilation से PCO2.
So at least इधर तो PCO2 40 is थोड़ा सा managing. इधर with this
orange.
So with this bicarb and with this PCO2, I feel this.
Anyone want to add anything more here?
तो मैं आता हूँ.
देखो लिख दिया कुछ.
PCO2 is less, means it is more likely respiratory, and this is 7.2 acidosis. तो ये respiratory acidosis हुआ, and bicarb is 18. Normally bicarb is 24 to.
Anyone wants to stop him right here? He's saying that respiratory acidosis. Nikhil, go to.
It is not respiratory. Bicarb is also low, so metabolic we can.
PCO2 ज़्यादा जाएगा.
16.
It is metabolic acidosis.
Metabolic acidosis.
Compensation secondary respiratory acidosis. But sir, metabolic takes chronically it takes time like but actually.
मैं खाली तुमको पूछ रहा हूँ. What is bad? What is you have said this is bad, and you are gonna give me a reason till now. You are just saying that the PCO2 is 16 is somehow managing. Is what you told me. So that's not the answer. So sit down. So that's first you must that is why you must understand the pathophysiology of asthma. Without understanding the pathophysiology, you can answer these questions. Okay, for that you are partially right. The ABG that is bad is this side ABG. It's very bad. This is peri-intubation ABG. This one is peri-intubation. This one. Okay, whereas this one is an ABG for all practical purposes that patient will come out of. Okay, that's the difference between both of them because this is I'll explain to you why. Okay, so asthma. Let me just get another chair. This chair is so asthma is not. That's why asthma you must understand very carefully. Okay, now what is the problem with asthma? What exactly is the problem with asthma? What is happening in asthma? What is the pathophysiology? There are 3-4 things happening. What are the 3-4 things happening? What is happening? First, there is smooth muscle constriction. The bronchial smooth muscles are constricted. Since the bronchial smooth muscles are constricted, there is a reduction in air movement. And that's why you hear the sounds. Small airway disease, the sounds you hear, no, wheeze you hear, ronchi you hear, because it's like a balloon. No? In a balloon you stretch it, whatever pee sound आता है वैसा वो sound आ रहा है उसमें. You understand that wheeze is coming from inside, the ronchis are coming from inside because of that reason. Come back, huh? Come back. Huh? So that's a difference. You understand that the smooth muscle constriction. Apart from that, what is also happening is there is edema of the airways. There is edema of the airways. So pathophysiologically there is smooth muscle constriction. Second thing, you have edema of the airways, and third there is mucus inspission. There is mucus, and it is these three things that are actually causing asthma. Asthma is a difficulty in movement of air. You are difficult to move air is asthma. Okay, when it is difficult for you to move air in and out, it is asthma. Okay, very difficult to move air in and out. And why is this difficulty occurring? A, because there is smooth muscle constriction. B, there is mucus inspission and over there, and 3, there is inflammation of the airways. All these three things together causes the movement of air to be very, very difficult. When this is reversible, this is called as asthma, and when this becomes irreversible, this is called as COPD. Clear? Huh? This is simple. Till now, this is simple. Huh? Till now, this is simple. This means to say when you move air, means you are exchanging carbon dioxide. When you are moving air, there are two things that are occurring. One is oxygen is going inside, and second thing, carbon dioxide is getting exchanged. If carbon dioxide is getting exchanged, what should happen? The carbon dioxide should reduce because it's getting exchanged. Since carbon dioxide is exchanging, it should reduce. So in a conventional asthmatic patient that comes to you, the carbon dioxide should be high or low? Less, because it is exchanging. If it gets bad, he is unable to exchange. What will happen to the carbon dioxide? So what is happening to that patient? He is unable to exchange. Are you understanding? So if a conventional asthmatic patient comes to you, he is breathing like this, your PCO2 should ideally be 21, 22 or 19, 10, 11. This should be your PCO2 because he is breathing heavily. He is able to exchange the gas. But the moment he stops exchanging the gas, that is where the problems start occurring. That is when the patient becomes peri-intubation. So what is happening on that side? He stopped exchanging that gas. Carbon dioxide gets exchanged quickly. Oxygen takes a long time to dissociate. Are you understanding? So that's why when you have a ABG that looks near normal in an asthmatic patient, you have to be very, 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 very worried. Because if the ABG is looking like normal, this patient is about to arrest. This patient is about to stop breathing. This patient is going to not have a good outcome. Are you understanding this? Clear? So you have to be careful. So what are the indications to say that the patient is very, very sick? What are the clinical signs and symptoms that you would see and say that the patient is sick? Can you tell me some signs and symptoms?
Tachypnea, respiratory rate more than 35.
RR is fast, yeah. Distress is there.
Stress,
There
use
is
of
accessory muscles of respiration, which includes
sternocleidomastoid,
alanezi and what do you see in the abdomen?
abdomen breathing pattern is a paradoxical.
Yes, paradoxical breathing. So once you say respiration, you start talking about paradoxical respiration, alanezi and sternocleidomastoid being working too much. What is the position of the patient?
Tripod position.
Tripod positioning. So tripod positioning. So once you talk respiration, you talk about tripod positioning. Diaphoresis. Okay, tripod position, diaphoresis. Okay, so these are all, and a very important statement is unable to complete sentences. So you must, if you are looking at a patient of asthma, you should be telling all of these things together to call it severe exacerbation of asthma. Okay, severe exacerbation of asthma. Okay, you have to tell all of these things when you talk about severe exacerbation of asthma. Okay? Now tell me, what is because of this airway becoming small, what do you think is occurring inside the chest, Supriya? Because the airway is going small, what is exactly happening inside the chest?
So patient is not able to exhale completely.
Very
because
good.
of which air trapping is.
Why is the patient not able to exhale?
Sir,
If he is not able to inhale, he should not be able to exhale also. मतलब ये दोनों inhale भी नहीं exhale तो वाका वाही रहेगा ना?
sir,
You understand the question? Then what is it?
so
What is it?
inhalation is active procedure.
Yes.
Whereas exhalation will be passive.
Yes,
So
yes.
with a constricted airway, exhalation will be difficult.
One thing.
And,
Second thing.
um,
So when you say elastic recoil,
Elastic.
when you say elastic recoil, means the airway has to again become normal. It does elastic recoil. Okay. What is happening in this bronchial asthma is this elastic recoil is not there. The elastic recoil is not occurring. So what happens is air is moving inside in a fashion, but the elastic recoil is not occurring. Since the elastic recoil is not occurring, expiratory airflow limitation. The word is expiratory airflow limitation is occurring. What is the word? Expiratory airflow limitation. What does that cause? So what does that cause, Supriya? Four क्या बोला? Clear, huh?
So
So what is happening? Now that you said expiratory airflow limitation is occurring, what is happening?
air trapping is occurring. So CO2 will increase.
Why is the patient like this breathless? The question is, pathophysiologically, why is the patient? You just now said alanesi, patient is having pursed lip breathing, patient is diaphoretic, patient is tripodic. Why is that occurring? We just now discussed the pathophysiology. You said that the patient is having expiratory airflow limitation because of the fact that it is not recoiling back, and so there is gas is not exhaling out. So why is the patient coming like this tachypneic?
Because CO2 wash out when ventilation is not adequate.
No. What is the pathophysiology said? You said right that expiratory airflow limitation. So where is the air remaining?
It's at the alveolar.
It is remaining at the alveolar level.
Air
So when the air is remaining at the alveolar level, what is happening to the diaphragm?
Distension of alveolars
The diaphragm will
Is going
down.
lower. That is the answer. So what is happening is because of why are you breathing? Because there is a difference between your mouth and the alveolus. You are breathing because you are able to move in air because the pressure over here is low and the pressure over here is high. That is why air is coming from outside to inside, right? Air is coming from outside to inside because you are breathing. Your pressure outside is more. Atmospheric pressure coming from inside. Negative pressure, plural pressure. Plural is negative, -4. So since you are negative, that's why बाहर से हवा अंदर आ रहा है. Simple. Now what is happening in expiratory airflow limitation? In expiratory airflow limitation, if this is your alveoli, rather than that collapsing, rather than the airways collapsing, the airways expanding, the airway remains collapsed. Since the airway remains collapsed, the air that is accumulating during inspiration is unable to get out. The air is unable to get out. You are understanding? Since this air is unable to get out, what is happening here inside? What kind of pressure is getting formed over here? Positive pressure. Now the difference between the top and the layer is reduced. Is less. So because of which movement of air is actually reducing. Not only that, what is also happening? Let us take that this is your lung. Okay, let us take this is your lung. Okay, let us take the lung of an asthmatic. And what do you find the difference? Huh? Hyperinflated lung, because you are keeping on inflating. So what is happening? What is the difference between both of these? Diaphragm. The diaphragm which was there so much. Okay, this is your diaphragm, say for example. The diaphragm has got so much space for it to move so that it can create that negative pressure. You understand? It has so much space for it to move so it can create the negative pressure. What is happening over here? Diaphragm is right here. The space is much reduced. So it cannot create that negative pressure. So the patient sits like this. He can't move that air because he is unable to move that air. That's why he tries to create a positive pressure, negative pressure by creating pursed lip breathing. Are you understanding? So this pathophysiology is very important for you to understand. Okay, the mechanics of the diaphragm is such that it doesn't allow the patient to move air from outside to inside because of expiratory airflow limitation. Clear on this? And that is why you get this manifestation of the patient being breathless, alanesi flaring, and patient just going down. Are you understanding? And since there is no gas exchange occurring, your PCO2 might go up and the patient might go down. So any doubts till now? Have you understood the pathophysiology? This phenomenon of air accumulation, the process is called as expiratory airflow limitation, the phenomenon. The entire process of this occurring is called as dynamic hyperinflation, and the pressure that develops over there is called as intrinsic peak. Three different terminologies I told. The process is called as expiratory airflow limitation, and there are chapters on expiratory airflow limitation. Okay? The process is expiratory airflow limitation. The problem created is called as dynamic hyperinflation, and the amount of positive pressure that is at the end of expiration is called as intrinsic peak, also called as unintentional peak, also called as auto peak. They are all the same thing. Okay, so the pressure inside is called as intrinsic positive end expiratory pressure, intrinsic positive end expiratory pressure, or unintended positive end expiratory pressure, or auto positive end expiratory pressure. The movement of this air and this phenomenon is called as dynamic hyperinflation. Okay, dynamic hyperinflation because it's dynamic. The reason why this is occurring is because of expiratory airflow limitation. This is entire pathophysiology of asthma in a nutshell. Clear? Am I clear on this till now? So we are going to deal in today's talk on severe asthma, the severe nature of this asthma. This is the patient that we are talking about, the severe asthma patient, who can't complete a sentence, who by definition peak expiratory flow rate is less than 30, but we can't do PEFR at that time. It's not possible. You understand? You can't do PEFR and all that time. Patient is not able to complete a sentence. He is diaphoretic. Patient is going haywire. Is in distress. This is the kind of patient we're talking about. Clear? Any doubts till now? So this does not mean that this patient requires an antibiotic. This is just because of some other reasons. It could be just extrinsic. It could be just because of climate change. It could be just because of maybe an infection. It may be because he's omitted his medicines. It may be because of various reasons why a patient may go into an acute exacerbation of asthma. The question we are going to face whenever we are treating patients are exacerbation of asthma. They are not just normal asthmas. They are going to be exacerbated asthma that comes to you. Clear? So right from the starting, what do we do? So what do you think you'll do in a patient who comes to you, who comes into your ICU with an acute exacerbation of asthma? What are the few things you want to manage? We are going to management directly because there's not much apart from this pathophysiology, right? So what are you going to do in the management? Let's see what you're going to do.
We'll try to maintain.
So
SPO.
first, let us understand what is our armamentarium. Okay. So what are armamentariums? What are the things you're going to use? Probably going to be using in your mind. You have NIV in your mind. You have. What is all in your mind? NIV. Write it. Such a board will. So he's telling everything. You write everything. So write on the board. Board will क्या? So you have NIV in your hand. Then.
Inhalational beta 2 agonist.
Inhalational beta 2 agonist. लिख दे. Inhalational beta 2 agonist. Then. Because you should have something in your mind which you're going to use, na? Agar I'm going to cook something, so to cook something I have a lot of ingredients in my. That's there in my mind when I'm actually trying to cook.
Corticosteroids.
Inhalational corticosteroids. Okay. Then go ahead. He took that lecture of all those. What are the drugs?
Doxycycline.
What is it called as? You should always talk science, okay? Always talk science. Anyone wants to add quickly? Right, methylxanthine, right? Methylxanthine. So you just now said methylxanthines. Then?
Anticholinergic.
Anti-muscarinic drugs. They are called as anti-muscarinic drugs. So write anti-muscarinic drugs. Right terms, always please at all right terms, otherwise you will, all your life you will remember it. Anti-muscarinic. So you have inhalational anesthetist, inhalational beta agonist, inhalational corticosteroids, methylxanthine, anti-muscarinic agents. Then what else? IV steroids, systemic steroids. Then magnesium. Right, magnesium good. Magnesium. Then adrenaline is what? Beta 2 agonist. You already told that.
Yes,
Beta 2 agonist. We are putting it so that you remember what is what. Beta 2 agonist.
Injectable.
So injectable beta 2 agonist.
Substitute.
So injectable, the writing is injectable beta 2 agonist means beta 2 agonist is adrenaline. We are talking beta 2 effect adrenaline, right? Yeah, next.
Anti-IgE omalizumab.
Sorry?
Anti-IgE.
This is severe asthma.
Okay.
So talk about severe asthma. Anything more? That's it? Endotracheal intubation? So endotracheal intubation is required. Then go ahead. Anesthetic gases? Anesthetic gases? Heliox. Then phosphodiesterase 3 inhibitors. Antihistaminic agents. IV anesthetics. Not ketamine. NMDA receptor antagonist. So remember to talk science. These are all drugs, but you first understand, because then only you understand the mechanism of action. If you don't really talk like this, you will never understand the mechanism. NMDA receptor antagonist. IV anesthesia is basically for bronchodilation. Now NMDA receptor antagonist for treatment.
5-oxygenase inhibitors.
So first you put this. What we just now say? NMDA receptor antagonist. Next. So, so you have so many things to discuss when you talk about asthma, severe acute exacerbation of asthma. Now, Nikhil, now the patient comes back to you. You have a patient in front of you. You have a patient in front of you who is quite sick, who is breathless, who is clearly having difficulty in moving in air and moving out air. He is at a pulse rate of 130. His BP is 140. His oxygenation is showing a saturation of 92. Okay, he is in front of you. He is a male. He is a known asthmatic. So you know that this diagnosis is asthma. Okay, he says that this has started yesterday after I have gone out after Diwali, and he's coming to you. Okay, and what are you going to use? You have got a whole lot of things right in front of you in the room. So what are you going to use and how are you going to use them? What are you worried of? This patient is very anxious. Okay, this patient is in front of you and he's very anxious. What are you worried of? He's anxious. Going to be anxious. No, anybody will be anxious. Have you jumped into a pool and not able to swim? You've seen that, right? You get anxious because you can't move in air. Anyone knows swimming here? Everybody knows swimming here? No. Have you jumped into water in time? Huh? And you've seen how you feel? That's the feeling these patients will have because they can't move in air. It's like they can't move in air. That's the feeling that they're having. Huh? So obviously they will be very, very anxious. You can't have a person who is asthmatic and it's not possible only. Okay. So what are you worried about? What are you worried about? Forget about this. What are you worried about?
With anxiety, patient might land up into pseudo retention and
what will happen with this anxiety? When you are anxious, what happens to you? Now I am asking you a question. You are anxious. What's happening to you?
tachycardia.
Apart from tachycardia? Tachycardia? Yeah, that's what happens. The moment you, yeah. So if the patient is having expiratory airflow limitation, and the person who's studied a lot of respiratory is Laurent Rochard, phenomenal person. If you hear him to talk, you realize what science is all about. So expiratory airflow limitation, written articles on just expiratory airflow limitation, 6-7 pages of just expiratory airflow limitation. Okay, so expiratory airflow limitation. Okay. What is happening because of expiratory airflow limitation? There is going to be a RR that is going to be high. Apart from this, there is going to be anxiety because he is unable to move in air. Right? Anxiety is going to cause the RR to increase further. When the RR increases further, what is going to happen? There is going to be increased amount of anxiety. This increased amount of anxiety is going to cause increase in expiratory airflow limitation because RR is increased, expiratory time is reduced. Expiratory time is further reduced because RR is increased. You understand? So you have a vicious cycle happening. You have a patient who's in front of you. He has expiratory airflow limitation. You have an RR that has gone high, and with this RR that has gone high, this patient has got into anxiety. That anxiety has caused more RR to go high. Since RR has gone high, expiratory time is further reduced. More expiratory airflow limitation, the vicious cycle is going on. Tell me what I'm going to use. So this means what? Time is the essence here. This means time is the essence. You got to act fast. If you don't act fast, you're not going to. This patient will worsen. And the basic pathophysiology that we're dealing with is basically bronchial muscle constriction, smooth muscle constriction. This is the basic problem. So what are you going to use?
Beta-2 agonist.
But they further cause tachycardia.
What will you use? So you have the whole thing in front of you. You know the pathophysiology. You know the problem that is occurring inside the patient. You have to combat it. You have the whole things along with you. You can do what you want to do. You have to choose one of the drugs. We can choose more drugs also. Huh?
I'll give antimuscarinic.
Ipratropium. That is anti-muscarinic drug. Okay. Anybody else wants to try something else?
Tachycardia.
So at first nebulizing with beta-2 antagonist.
Beta-2?
Agonist, sorry. Beta-2 agonist, levosalbutamol.
So who wants to do beta-2 agonist? Who wants to do anti-muscarinic agents? So who wants to do beta-2 agonist? Put your hands up. Come on, only or 1, 2, 3. Sachin, what do you want to give?
Ipratropium.
Both. Beta-2 agonist. Anti-muscarinic. So the answer is beta-2 agonist. The answer is to give it. Why is tachycardia there?
Because of anxiety.
So, first we'll give some anti-anxiolytic.
So what you can do first and foremost, the first thing you will probably give, ideally the first thing you will probably give would be a steroid IV. Why? Because it's going to take time for it to act. The first thing, because steroid, how is it going to work? How is steroid going to work?
Inflammation.
So steroid, how does steroid, why is it going to take time to work? That's the question. How is it going to do that? So it will first go into the blood. From the blood it will go to the nucleus. In the nucleus it will go in and act on the nucleus, saying that okay, reduce the amount of interleukins. Then it will reduce the amount of interleukins, then the inflammation will come down. So then the inflammation will come down. So it's going to take a while. You understanding? It's going to take a while. So that is why, not that it is going to work first, but I want to give it so that it works. If the earlier I give it, the earlier it will work. It is going to take some hours before it is going to work. What would be the dose?
I record 100 study
Or prescribed dose is methylprednisolone. The dose would be, what would be the dose?
0.5 g.
What will be methylprednisolone dose? So in community acquired pneumonia, what was the dose?
0.5 g per kg.
So here the dose will be 1 milligram per kilogram and not more than 80 milligrams. Okay? Yeah. So the dose will be 1 milligram per kilogram. So you cannot give more than 80 milligrams. Okay? So you may give around 40, 50, 40 milligram BD. You can do something like that. You understand? You don't need 500 milligrams and 1 gram of methylprednisolone and all. Okay? The prescribed dose is not more than 80 milligrams. So 40 milligrams BD is more than enough. So that will be my first dose I'm going to give. But what I'm going to work with is going to be beta 2 agonists. The beta 2 agonists that we know about are few. Which are the few beta 2 agonists that we know about? We know levosalbutamol, we know adrenaline, and the rest of this formoterol and things like that. Right? So the drug of choice for us would be levosalbutamol. And how much levosalbutamol would you like to give?
0.6.
So it's 1.2 milligrams of levosalbutamol, which has to be given
4 times every 15 minutes.
Every 15 to 20 minutes. You have to give levosalbutamol. It can be given as an infusion at
6 ml.
10 to 15 milligram per hour. Okay, the dose for levosalbutamol as an infusion would be 10 to 15 milligram per hour. Clear on this? 10 to 15 milligram per hour will be the dose of levosalbutamol if you want to give it as an infusion in the nebulizer. We have seen the nebulizer being given as an infusion. So the dose is 10 to 15 milligram per hour. Okay, so when you are giving it as an infusion through our nebulizer, we are giving it as 10 to 15 milligram per hour. Clear on this? Levosalbutamol? So how does levosalbutamol work? What is the pathophysiology?
It will act on smooth muscles.
How?
That's
So there is on
GCMP or
yeah. So क्या करता है ये simple अपना this has got, it is coupled to the G protein receptors. It works on the G protein receptors, then stimulates cyclic AMP. Cyclic AMP causes inactivation of myosin light chain kinase and activates the myosin light chain phosphatase, and that causes smooth muscle to relax. It inactivates the myosin light chain kinase and activates the myosin light chain phosphatase, which causes smooth muscle to dilate. Okay, so it's working on cyclic AMP coupled with the G protein receptors in the smooth muscle of the bronchial tree. Simple? So that's how beta 2 agonists you use. What is the other beta 2 agonist you'd like to use? The other beta 2 agonist that you'd like to use over here, say in the event that patient is not improving, is what? Sorry? How do you use adrenaline in these cases?
So we can use both the ways, inhalational or subcutaneous.
So the ideal drug to be used in these cases is subcutaneous, because you want the bronchial this for other drugs that you're going to use. So I would be using, how much I would give? 0.3 milligrams. 0.3 milligrams IM. Okay, and in the event that but the problem with 0.3 milligrams IM is every 20 minutes you give it. 0.3 milligrams every 20 minutes you give it for 3 doses. 0.3 milligrams. However, 0.3 milligrams IM dose se acha would be IV dose of 5 to 10 micrograms. You understand? 5 to 10 micrograms would be an ideal dose rather than giving 0.3 milligrams that's inside IM. You understand? So 5 to 10 micrograms, that's what we do. When we make a double dose adrenaline, we make 3 micrograms per cc. So it is 2 cc out of that 3 double dose that we use. We are using here for every patient double dose adrenaline. When we make double dose adrenaline, what are we doing? We are making 3 micrograms per cc. So when you are doing 3 micrograms per cc, give 2 cc out of that. You understand? And why do you want to give IV drug? Because IM we don't know whether how it is going to absorb, what is going to absorb, and once and all. Once it goes in, you cannot take it out. IV is going in, coming out quick. You understand? So you can give IV adrenaline 5 to 10 microgram. Clear? Adrenaline. This is another beta 2 agonist that you can probably give in these cases. Which is the other drug you want to try here? So this is the first 1 hour. Okay, we are in the first 1 hour. In the first 1 hour, we are doing a lot of things. In the first 1 hour, you have already put an order saying 1.2 levosalbutamol 10 or every 15 minutes. Every 15 you put it on the screen. Nebulized levosalbutamol every 15 minutes. You put it on the sheet, and you have written IV methylprednisolone 40 milligram stat. You have written that. Next drug.
So just adrenaline IV 5 to 10 or like 100 cytokine.
3 times again.
3 times.
Yeah, 3 times again. Then the next drug I would want to use would be an anti-muscarinic agent. Beta agonist हो गया है निहारिका. So it will be anti-muscarinic agent. Which is the anti-muscarinic agent we are talking about? Either ipratropium or glycopyrrolate. Okay, or atropine. You know, it's an anti-muscarinic agent. So which is the anti-muscarinic agent that we are using? Ipratropium bromide. How do these work? How do these work? Okay. So how do they work? How do anti-muscarinic agents work? So M3 receptors. Say the M3 receptors are known to release cyclic GMP, and cyclic GMP is known to cause smooth muscle contraction because it works on it inactivates these myosin light chain things. So it actually acts anti-muscarinics and thus acts against the M3 receptors, and that's how ipratropium bromide works. So what would you write on the sheet of ipratropium bromide? What would you write? You have to write something. You have written levosalbutamol, you have written IV steroid. What are you going to write? What are you going to write? Yeah. So right, you're going to write glycopyrronium or ipravent. You're going to write ipravent. You're going to ipratropium bromide. 500 microgram will be given 3 times in the next 1 hour. So this is 1 hour management. What we're talking about is 1 hour management. You understand? Because in 1 hour it's break or break. These patients in 1 hour it is make or break. Because in 1 hour time he's going to get into that routine and get integrated. Okay, so when you come to in 1 hour's time, you're going to write every 15 minutes you're going to give levosalbutamol, every 15 minutes you're going to give ipratropium bromide. So you're giving 6 things in the next 1.5 hours max. Right? 6 doses are going in. Clear on this? Every 15 to 20 minutes you're giving all of these things. You understand what I'm saying? So this is how it's going one after the other. Okay, so you have given that also. So in short, we have done 2 things. We've actually decided to give this patient a beta 2 agonist, and we've decided to give either it's going to be nebulized or it is going to be IV, or of adrenaline. And when you say the next drug that we're trying to give is going to be an anti-muscarinic agent, which is ipravent, ipratropium bromide. This also we have decided how to give it. Now, when you come to nebulization, okay, nebulization, we'll come to that when we're going to nebulization. How do we give this nebulization? It is known that we can use an NIV to ensure that the nebulization goes in much more better. The delivery of the drug usually is much better when you're using an NIV. So probably use an NIV here and try to deliver the drug. Okay, try to deliver the drug better. Clear on this? So NIV will help to do 2 things. What does it do? A, it splints open the airway. It is known to splint open the airway, and it also changes the pressures so that you can move in air a little bit more easier. Right? It will help to move in the air. It will also help to splint the airways. This is theoretical reasons why BiPAP should be used, NIV should be used. The theoretical reason to use NIV is that it splints the airway open, that is, it keeps the airway open, and 2, it tries to move in air because it creates a more positive pressure from top to inside. Clear? Understood? The third reason why we want to give NIV is because it facilitates drug transfer from outside to inside. Usually the drug that is going inside the body is only 10%. It tries to move that 10% in properly. Clear? Am I clear till now? Now let's go to what happens. What happens if the oxygenation is on the lower side? If the oxygenation is on the lower side, you would probably want to either quickly intubate this patient or give some oxygen. So when will you give oxygen? Do you have a benchmark when you want to give oxygen, or don't want to give oxygen? Say your saturation. What is the number of saturation which you want to give oxygen?
The target should be 88 to 92%.
Well, and why is that so? What if happens if this is asthma? This is not COPD. This is asthma, na? What you are talking about is COPD, where you don't want to give because there will be hyperoxia and hypercapnia and patient will become intubated, ventilated and things like that. But here this is asthma. Why are we concerned with oxygenation here? Why are we concerned? Any idea why are we concerned with oxygenation? Your answer is right that you want to keep it above 92. But above 92, not 80 to 92. But why? Why? Any idea? So there's a lot of physiology in this. That's why you must understand what it is. So, so what is that?
So like already there will be CO2 trapping. There will be hypoxic pulmonary vasoconstriction.
So what is happening?
So air stealing will occur. I mean to say.
I explained you. So this is the alveolus, right? This is alveolus, right? Now this alveolus, because it is hyperinflated, is actually having the response to this hyperinflation is there is going to be a very thin vessel here. Whereas there is another alveolus that is normal, where the pulmonary is big, right? You have an area of the alveolus which is hyperinflated, and since this is hyperinflated and it is not taking part in gas exchange, it is not taking part of the body is miraculous. It actually causes hypoxic pulmonary vasoconstriction in that area. It's hypoxic. It's not moving in air. Since it's not moving in air and moving out air, this area is hypoxic, which causes this area to become hypoxic pulmonary vasoconstricted. What does this do? It prevents shunting of blood. If this was also as big as this, non-ventilated, non-oxygenated blood will actually mix. तो उन्होंने क्या कर दिया, इसको पतला कर दिया है. Are you understanding? So beautiful. It's amazing that the body does this. Okay, it does this because of which this patient is somehow maintaining. Now you came inside and you gave oxygen. The moment you come and give oxygen, what is really occurring? When you give oxygen, oxygen is moving inside. Carbon dioxide को कुछ नहीं हो रहा. Oxygen is moving inside. Okay, oxygen moving inside. Carbon dioxide is not moving outside. What is going to happen to this area? This area will become big because suddenly hypoxia. It's not hypercarbia. It's hypoxia. You leave the hypoxia. So this will become as big as that. When this becomes as big as that, the blood which is responsible for moving up and down here, carbon dioxide and oxygen, is now getting transferred over here. There is no more movement, but the carbon dioxide is still moving inside. So this patient will actually cause increased carbon dioxide. Are you understanding? It will cause increased carbon dioxide because now there is no gas exchange. Now the carbon dioxide exchanging here, it is now moving from here to here. The carbon dioxide which is supposed to exchange here is now moving from here to here, causing increased PCO2 in the blood gas. You understood, or should I repeat again?
So response is blunted. No, HPVC is exaggerated.
Nikal gaya. It's out, no? So what is going to happen? Again, I am explaining to you. Initially your pathophysiology is such that this is your hypoxic. This is the one that is having the very small expiratory airflow limitation. So this area is having very less gas exchange. So it's hypoxic as well as hypercarbic. Okay, it is hypoxic as well as hypocarbic. Both the problems are there here. And because it is hypoxic, this vessel over here has become vasoconstricted. That's called hypoxic pulmonary vasoconstriction. Clear on this till now? It's called hypoxic pulmonary vasoconstriction. So now this is saving your patient. Now what has happened? You decided, let me give some oxygen. And you gave oxygen here. The moment you give oxygen here, what is going to happen? The hypoxic pulmonary vasoconstriction is moving out. Okay. Now what is happening if the hypoxic pulmonary vasoconstriction is moving out? This is becoming bigger. This artery is becoming bigger. Now when this artery has become bigger, what is going to happen? The blood is going to come from here and fast move into this part. Since it's moving from here into this part, okay, there is no gas exchange happening. Only oxygen has come in. There is no exchange that is occurring. Exchange is supposed to occur here because this is moving air. Because this is bronchoconstricted, this is open. Are understanding? This is moving air. So carbon dioxide exchange is occurring here. Now most of the carbon dioxide now is fast moving into this part because it has lost its vasoconstriction. You understand? So what happens because of that? The carbon dioxide which is supposed to get out of the body now remains inside the body and your PCO2 starts going up. So if you have a patient in asthma and you are going to intubate your patient, this is what you have to keep in your mind. One of the things you're going to keep in your mind is if you're going to intubate your patient and this patient is already having cardiac problem, this problem, that problem, and carbon dioxide goes up, this patient will arrest. Are you understanding? So that is why if the saturation of this patient is at 88 and 87, maintain it at 88 to 87. Our reason to take care of asthma patient is to just maintain him till the drugs work. It's not to treat his hypoxia. It's not to treat his carbon dioxide. समझ में आ रहा है? Their entire thinking of an intensive care doctor when you are managing asthma is to maintain him the way he is till the drugs work. Are you understanding? So in that manner, don't treat the hypoxia, don't treat the hypercarbia, don't do all those things. Let it remain like the way it is. Let your drugs work. When your drugs work, all this will get treated on its own. So if you try to treat the hypoxia by giving oxygen, you will create this problem. So you just want that some hours so that the bronchoconstriction relieves. You understand? That's why we accept carbon dioxide. That's why we accept some hypoxia. You understand? We accept carbon dioxide to go up. Let it go. No problem. Okay? You understand? That's why accept all these things. Don't let the physiology change at that moment. Clear? Clear on this? So I would want to maintain around 90. I don't want it to be higher. I don't want it to be higher. Because the moment I go higher, this I will lose all these things, which is protecting you. Clear? Clear on this? You will also notice this when you are actually after the intubation, you will feel the PCO2 be high. So this is what happens if you don't understand pathophysiology. An untrained person will do all this nonsense. What they will do? They will first intubate this patient. Then they will repeat an ABG. They'll find the carbon dioxide to be 50. They will increase the RR and cause more problems. Are you understanding what happens? Untrained person not knowing pathophysiology will do this thing. What they will do? They will intubate. They will send a blood gas. Or they'll see the ET to 50 आ रहा है. वो ET to 50 देखेगा और बोलेगा RR बढ़ा दो. You know that's what a donkey does in the ICU. Then they will increase the RR. The RR will go up. Once the RR goes up, the expiratory airflow limitation will increase. Patient will go into a vicious circle and die. You understand? So you as a doctor in the ICU, you must understand the golden line that I'm telling you is you don't do anything to treat the hypoxia or hypercarbia. You are only maintaining the patient till these drugs work. समझ में आ रहा है? Clear on this? Just maintain the patient the way he is and just work till that drugs work. Simple. ये तो ज़्यादा नहीं हो रहा है ना अभी तक? अभी तक तुम लोग को हेवी नहीं जा रहा है ना? ये अभी बंद करें अभी.
What is the highest permissible level? Is it
for PCO2? 7.12.
Till pH drops to
90 is so we had a recent ISTHMA meeting where we had one person who showed one PCO2 150 and patient did well. 150 PCO2. Niklesh from Choitaram showed that case in Dorpe. He said 150 it was there and patient did well. So we really don't know what level of carbon dioxide will harm, but we know for certain that if it's pregnant, if the patient has got pulmonary hypertension, if the patient has got raised intracranial pressure, I will not want the PCO2 to go up. That I know. But I don't know what is high. On an average, we say when you reach 90 of the PCO2 or when the pH drops less than 7.15, it's a little bit discomforting. Okay, it's a little bit discomforting. Okay, that's what we say. You understand, no?
So CO2 का जो disadvantage होता है hypercarbia के वो नहीं आएगा patient में अगर if we are giving long time it's
nothing will happen. So hypercarbia is not dangerous at all. Hypercarbia is not dangerous at all. So in COVID we have patients of 90 and 80 and 90 maintained for 5 days and 6 days during COVID because we wanted to keep the tidal volumes on the lower side. We want to keep the RR low.
So what about CNS symptoms, cerebral edema?
No. Cerebral edema will come only when it's problematic with respect to cerebral autoregulation. You have a beautiful mechanism in your brain called as autoregulation. It's too good. Okay, so autoregulation when it is there, nothing happens. Your autoregulation potentials is beautiful. So that's why you don't get a headache. You know, in spite of if you stop your oxygen, you don't get a headache. You don't ventilate, you still don't get a headache. Otherwise, you get a headache every time you stop breathing, right? That's not occurring because autoregulation is working beautifully. Understanding? It is when your autoregulation is not intact when problems will occur. For example, traumatic brain injury. So I would not do this in traumatic brain injury or patient who is having a raised ICV. That's what I said. Yeah. Where the autoregulation may not be intact.
Cerebral autoregulation range is wider than all other organs.
Yeah, yes. Widest range it has. That's why the brain is the most beautiful organ of our body. It's the most protected organ of our body. So it's at the same time that's why we can take a lot of liberty with the brain. You know, the most protected of the organs it is. Clear on the
So
carbon
what
dioxide
are the
front?
acceptable values in pregnant patients came with acute exacerbation?
So there again, we will not want to go high on the PCO2. So there again, we'll be very careful. Pregnant patients, completely different ballgame. You won't see pulse rate, you won't see changes. A lot of changes are there in that. Yeah, I would keep repeating heart, more monitoring, more seeing optic nerve sheet, and all that I will keep doing. Monitoring, there is no number if you ask me, but I know this much that I will not be going very high. As I told you, not more than 70, 80 ke upar nahi jaunga, most probably. Have I done it in the past? I've never had a patient that has had that problem with pregnancy. I've never had that. So if you ask me, is there a patient that's PCO2 has been to 90 and patient has been done well? I don't think so. I've had a patient who did that till now. But if it does come, I will still heighten my level of monitoring and keep it at say 70, 80 maybe. Because I know that it doesn't cause problem. Up to 150 there is no problem, we know that. Okay? It's very rare to have someone like that because these pregnant females somehow they are very protected because of their prostaglandins. Because the estrogen, progesterone, all these things, they're very, very high. So that prevents them to actually have any problems. They get better. All these pregnant females who are asthmatic, they get actually better. Once they get pregnant, they actually get better. Some even walk off their asthma also. Many of them. Okay, so now we are in a situation where we've decided on the drugs that we want to give. We've decided that how much oxygen to be given. The third last thing is how do I now tackle this part? How do I tackle this part? I have a problem here. I can tackle this also. So I am tackling my expiratory airflow limitation by using beta blocker, beta 2 agonists, by using antimuscarinic agents, by giving steroids. So we started by saying inflammation, we started by saying bronchial constriction, we started by saying mucus inspissation. We are tackling all of these by giving steroids, we are tackling it by giving antimuscarinic agents and beta 2 agonists, right? We have tackled this part that we talked about pathophysiology, but there is one more part over here, this is anxiety, which is adding to expiratory airflow limitation. Isn't it? How do you tackle that? What do you do this? What do you do here? It's whatever you can tackle in the first 1 hour I want to tackle. So I can tackle the anxiety. How do I do that? Yeah, so I want to use a drug. I want to use a drug that will help me to quieten down the patient and at the same time does not change the RR at all. Because I will not know what is happening otherwise. If I do something and the RR changes, okay, I will not know whether the patient is going down or whether it is my drug. Are you understanding? Ideally what should happen? I am giving beta 2 agonists, I am giving antimuscarinic agents and the RR is coming down. I know this patient is doing well. Right? But if I give a drug that drops the RR, I don't know whether the patient is doing well because of my beta 2 agonist or whether it's just respiratory depression because of the drug. So which is the drug I will use? Dexmedetomidine. That is the drug I will use. I will use dexmedetomidine. Now, how do I use dexmedetomidine? In fact, what is the way you should use it in any patient that is there in the ICU? How are you going to use it? And why is this such a great drug when it comes to asthma? A, it has got a bronchodilatory action. It does have a bronchodilatory action. Okay. A. Then it does not cause respiratory depression at all. There is no respiratory depression at all. Okay. How do you use this drug?
Loading dose we give by 1 max per kg IV over 10 to 15 minutes. Then maintenance dose 0.5 to 1 max.
How do you do this? Can you put this on? You have to write it to the patient's relative. I mean the nurse is there in front of you. You have to write it on the sheet. How are you going to write it on the sheet? Exact orders लिखो sheet पे क्या लिखने वाले हो?
So
you can rub this out and write the orders. You have to write the orders because these are all orders that you have to write. You can't ऐसा करके नहीं निकल सकते. You have to write it. You understand? Unless you write it properly, it makes sense, right? So let's write it down. Write down the orders.
So we usually need.
No. See, you write the orders. There you have the flowchart in front of you. Write the orders.
Suppose we have patient whose weight is.
You write the orders. We don't want to hear from you. Write down. Write down the orders 50 kilo individually. Write down. Because I'll tell you one thing. Why am I telling you to do this? Because in the asthmatic patient, you can't be thinking. It has to come subconsciously. If for that matter, any patient that you have in the intensive care unit in which you want to start dexmedetomidine, normally it's an urgent situation. isn't it? You have intubated, you want to start, it's something like that. So how do you do this? Come on. How much does desmetromidine have? Let's start like this. How much does the ampule have?
Sir, 400 mics.
So right. So okay.
Usually we use this equation, dose into A divided by concentration.
You write no. Tell me how much. Okay, take your time and write.
Okay. Dose is 150. Is commanded. I'll calculate.
So you've been
So 50 ml.
how much are you putting inside?
200
200
ml. So it will be 4 micrograms per 10 ml.
Wait. So somebody else wants to answer. Supriya, come.
So in 50 cc we will put 200 mics, which will be 4 mic per kg.
Per cc.
Sorry, per cc.
Okay, 4 microgram per cc. You understood this? समझ में आया अक्षर? 200 microgram in 50 cc. तो हो गया 4 mics per cc. समझ में आया इतना?
So now for 50 kg, in first 10 minutes we will be giving suppose 1 mic per kg हिसाब से. So at least we'll have to put it in 12 ml per in 10 minutes.
12 ml per?
In 10 minutes.
No.
That will be 50 ml per hour for 10 minutes. Same, no?
No. So sit. So that's why you should know how to do this, okay? Dexmedetomidine. So it's 1 point, you will start at 1.22, 1.2 to 1.4 microgram per kilogram per hour. Per hour. So you start at 12 ml per hour. Are you understanding? For the next 10 to 12 minutes. You understand what I'm saying? No. So it's 12 ml, not 12 ml per hour, not per minute. Okay, you understand? So 12 ml, not over 10 minutes. If you say 12 ml, it becomes loading bolus. You cannot give bolus of dexmedetomidine. Are you understanding what I'm saying? If you give bolus, patient will have bradycardia and hypotension. You can't do that. You can't do that. So you have to say start 12 ml per hour. On the infusion pump, it will not be 12 ml over 10 minutes. It will be 12 ml per hour. You say right 12, put 12 on the ml per hour and wait. You understand? Because the dose is 1 to 1.54 microgram per kilogram per hour. This is the dose. And after this, this will reduce to anywhere between 0.1 to 0.5 microgram per kilogram per hour. So it will be directly half or lesser than half. Maybe 2 ml, 3 ml. You understand? So you will start at 12 ml per hour. 12 ml per hour. And you will see what is happening. You will see what is happening. You are understanding? You will see what is happening. If the patient goes down, immediately I will come down. Okay. So how much time does this take usually? How much time?
If you are giving loading dose.
There is nothing like loading dose. There is nothing like bolus dosing here. It is only you want to give a higher dose to begin with. You can call it as loading. ठीक है. But there is no bolus. First of all, there is no bolus of dexmedetomidine. Okay. You are going to give a higher dose to begin with. Okay. How much time does this take?
10-15 minutes.
No, it takes much more than that. If you want to do this, it will take 25 to 30 minutes. Okay. It will take anywhere between 25 to 30 minutes if you do it like this. That's why. What is the problem? This is the problem in dexmedetomidine. The problem in dexmedetomidine is you don't have 30 minutes here. Are you understanding? You don't have 30 minutes here because it is going to take on an average 25 to 30 minutes to achieve that dose to reduce the anxiety such that the expiratory effluentation will come down. Are you understanding? So giving dexmedetomidine is a fantastic drug, bronchodilation. It actually preserves respiratory depression. It doesn't cause respiratory depression, but unfortunately it's going to take a long while. It can take a long time before it can start working. Right? So what do you do in the interim?
We can use bolus, haloperidol.
Yeah, so you can actually start the patient on some other short-acting drug, and the other short-acting drug that is there which does not cause respiratory depression is actually haloperidol. Okay, so you may want to give haloperidol, okay, which will not cause respiratory depression. Okay, which is the other drug you may want to use? Midazolam. Dangerous, extremely dangerous drug to give in this case. It's extremely dangerous drug. It will cause the sympathetics to go down and the patient might just arrest. Okay, so it's a very dangerous drug to give. Haloperidol is something you may try, but the same problem with haloperidol. What is the problem with haloperidol? It will go in and come out quickly. It will come out quickly. So one drug causes this, other drug causes this. It's low potency. But will come out also quickly. You understand? That is the issue. So haloperidol is a problem. Okay. Then which is the other drug that you can try? Peri-intubation. But what about this ketamine in a patient who's awake? Very difficult to do ketamine in a patient who's awake and breathing in front of you. Which is the other drug you can give? So one dangerous drug you can give is opioid. It's a very dangerous drug. Very dangerous drug. Dexmed you can still wait and watch. Opioid, very dangerous drug to give, because if you give opioid, there is going to be desperate depression. You will not know what's happening. But a good clinician standing bedside can actually figure out what is happening. If you put the patient on opioid with Dexmed on the background and you find the patient's wheeze coming down, auscultation getting better, the alanesi flaring lesser, and you notice that it is the airway that is improving and not the respiratory depression that is taking over, clinically you can still use the drug. Are you understanding? समझ में आ रहा है क्या बोल रहा हूँ? अगर तुमको opioid use करने को रोकने नहीं वाला है तुमको, लेकिन उसके लिए you need superior clinical knowledge to do that. You understanding? You should be certain that the expiratory airflow limitation is coming down. So I would not recommend it to opioid to anyone here at this moment, unless you are if you're giving opioid. If you want to use opioid, you have to stand with the patient. Stand right there with the patient, because you are doing something that can be very dangerous. समझ में आ रहा है? Clear? Dexem you can stand, go and tell the nurse, सो गए तो बताओ मेरे को. Are you understanding? But in opioid you can't do that. You have to be with the patient when you're starting opioid. Okay, the easier combination, haloperidol, Dexem. Easier combination, because it doesn't. Now you have the metric. The RR metric is right in front of you. It's easy for you to take care of that. Understand whether the patient is improving or not. Understand? Clear?
So low dose opioid, like suppose fentanyl, 15-20.
Less than 1 mic per kg.
But you will always be thinking, time छोड़ो. You will always be thinking, is there depression, respiratory depression coming? You will always be thinking that, because we know that opioid causes respiratory depression. We know that. So we cannot be certain and sure that the respiratory depression is occurring because of opioid or because the patient is getting better. So whatever dose you're going to give, there is going to be an element of respiratory depression. We will not be certain only what is happening. Are you understanding? There is no way to find out. So that's why the drug has to be a combination of haloperidol with dexmedetomidine. You understand? Clear on this? That's why this is all simultaneous treatment. First 1 hour में सब चल रहा है. You understand? Dexmedetomidine is a great drug because you can couple that with an NIV. You couple that with an NIV, you will give you the right result. You can titrate it beautifully. Okay? Then this is how you're going to tackle the expiratory airflow limitation. Now you decide to intubate because this patient is not improved. You can't just wait 2 hours and 3 hours and 4 hours with an asthmatic patient. This patient will die. So a patient is going to stay as asthmatic because he's not really improving, and you now decide to intubate this patient. So what is going to be your thinking when you're going to intubate your patient? You first are going to think about, okay, tell me what are you going to think, Aishwarya? So when you think, what are you going to think of intubation?
What drugs to give?
So what drugs would you want to give?
First sedation and then paralysis.
What is the drug? Amit? So your first drug you are thinking is ketamine. So yeah, so normally we say ketamine, already dexmedetomidine is on, so it will potentiate that. So you already have ketamine. You can also give another drug. Which is the other drug you would like to give? Propofol. Okay, the 2 drugs that can probably be used in these cases is ketamine and propofol. Now sometimes what Dexem, we did talk about Dexem being a great drug, but sometimes it does happen that Dexem also causes bradycardia. Don't chicken out. Bradycardia ho gaya, don't chicken out. Bradycardia ho gaya, no problem, start adrenaline. Because our entire thing is adrenaline is also going to work. Are you understanding? In this case, when you have a patient with an asthma and you have a patient with dexmedetomidine and that is causing bradycardia, this is the best drug that I can give as of now. So what do I do in this case? I start a small dose of adrenaline. It is going to work both ways. समझ में आ रहा है? You're understanding what I'm saying? So in spite of the bradycardia, just start a small dose of adrenaline. This is how you titrate clinically. Okay. Now you have decided to give ketamine as well as Dexem is already anyways on. Okay. And you are going to intubate this patient. Anything about the intubation, Amit?
Rapid sequence.
Rapid sequence of hair. Anything about the tube? Sachin?
We prefer.
White.
So what is white?
Damage.
Why do you want it to be white?
Minimal airway resistance.
There are two reasons why you want it to be white. One, you said is minimal airway resistance so that its expiration becomes simpler.
Expiration.
Because if you follow the tube, the expiration will be lesser.
Secretions.
Bronchoscopy. Tomorrow, if you want to do a bronchoscopy, because you have a respiratory problem, maybe you have a patch that is causing this, you want to do a bronchoscopy, I need a tube that is more than 8 number in size. I can't put a 7 number tube and then try to change it over. You understand? So I need to keep a tube that is on the higher side so that tomorrow if I have to do a bronch, I have the tube ready to put the bronchoscope inside. Because very often than not, you may not be certain about the differential diagnosis of asthma. Sometimes it does happen that it is a foreign body and that asthma is all foreign body related. Are you understanding? Sometimes it does happen that it is a foreign body or a vocal cord dysfunction that has caused it. You put that and thak karke everything just improves. So the answer is the moment you put the endotracheal tube and the peak pressure remains normal, you are not asthma. This is not asthma. If you put an endotracheal tube and you find the peak pressure to be 20, this is not asthma. Are you understanding? This is something else. This is some foreign body or something else that is there because you cannot have the peak pressures to be normal. You understand what I'm saying? So that is why you need a larger tube. The moment you put a larger tube, sometimes it so happens it just goes off and there's a foreign body, you need to take that out. You understand? Clear? So that's about the tube. What are the settings? What are the initial settings you'd like to give? So Nihari, what were the settings? Come. Settings on the board. So we decided the tube, we decided the drugs, we are deciding the settings, okay? Which are the settings you'd like to give? So how does ketamine work now? Now that we talked about ketamine, it's one of the drugs that you're going to use for bronchial asthma. How does ketamine work? So it's not an NMD actually, it's antihistaminic. It is antihistaminic. So actually the initial thinking was it actually acts on an NMDA receptor because that is what we've been thinking all the time, NMDA, but it's not really the NMDA that works. It's actually because the other NMDA receptors are not, other drugs are not working. Other NMDA, anti-NMDA receptor are not working. So it's really not the NMDA, it's actually antihistaminic. Okay, it's actually antihistaminic. Yeah.
So first of all, I'll go with low tidal volume.
Let's what is less RR
And increase the
so
time.
put the numbers. So put the numbers. Is 50 kilos.
Around.
Is 50 kilos. Okay.
Around 2.
Around you can put the number directly. 200. लिखो जल्दी. जल्दी लिखो. टाइप मत करो. 250. RR.
Then I used to I set on the higher side or 1:5.
If I were to
minimal.
what do you want to check? If I were to कितना आता है?
So that the saturation maintains around 88 to 92%.
Okay. And what is the mode?
Mode ACDC.
You want to ACDC, PC? You want to use volume control mode.
Volume.
Okay. And what do you want to check on the ventilator?
Look for auto peak.
Okay.
And in the volume graph.
You want to check for IP, then what do you want to check?
Peak pressures.
Peak pressures, then?
It should be less than 30.
Peak pressure. If it's less than 30, it will not be asthma. If it's less than 30, it won't be asthma. You understanding, no? Peak pressure will have airway. Peak pressures, go ahead. So you're done? Anybody wants to change anything else? Anybody wants to change anything or everything? Everyone is going to use this much. What can happen with this? Is this okay or is this problematic? This one?
Can increase my IE after some time.
Sorry?
IE.
What do you want to do?
Immediately will not increase. 1:3. To start with 1:3.
1:5. Yeah, 1:5 I'll start.
to start with, it should not be more. 1:3 is.
You are all concentrating on the I, which is itself wrong. You are all are concentrating on the I ratio, which is itself wrong, and I'll come to why you are completely wrong
So
on
your
this.
minute ventilation is very low.
So इससे क्या होगा?
So then if I ratio if we prolong, no, I mean to say, sir, I would have increased tidal volume a bit and RR also. So minute
Why you want to increase the tidal volume?
First, we'll see.
So during expiration, the amount of CO2, like the exhalation will be.
Is this tidal volume okay? Let's go one by one. Is this tidal volume okay?
It's 5 ml per kg.
300 at least. 320 per kg.
Why? You're right now that you want to give 6 ml a kilogram, but why? In fact, I would want to give even higher, but why?
To maintain at least optimum minute ventilation.
What are you doing in this 250? What is happening? How much is, see, this patient has got an anatomical dead space, huge dead space where there is absolutely nothing happening. You know, this patient has got a dead space because nothing is happening. We just not drew that alveoli and said that V2 mismatch ही नहीं हो रहा है. बराबर, they are actually anatomical dead spaces. So the dead space is much more higher. Usually dead space is 2.2 ml a kilogram. Usually dead space is 2.2 ml a kilogram. Here the dead space will be much more higher. So practically you are ventilating what? The dead space. In this case, with this 250. You understanding? So this is not the setting I would want to give at all. Are you understanding? This setting would be higher than this. So on an average, we could give anywhere between 6 to 8 ml a kilogram. The higher is better. 7 ml per kilogram would be the way I would start on. Okay, so maybe 300 to 350 is what I would start. You are understanding? Here the dead space is 2.2 ml a kilogram. So 120 to 130 ml is physiological actual dead space. It's anatomical dead space that is occurring. Right? On asthma, the dead space is even more higher. So you are practically ventilating 3/4 of the dead space. Means you are not doing anything. Means you are not. There is no gas transfer. You understand? So I cannot do this lower tidal volume. I want to give slightly higher than this tidal volume. Okay. Now all of you all, the first thing you are talking about is I ratio. What is this I ratio? इससे क्या होता है? मतलब what is happening to I ratio? What is exactly happening?
Expiratory time
Is prolonged. And why do you want to do that?
to remove the carbon dioxide inside.
To remove the carbon dioxide, you want to give more expiratory time, right? This is what you are thinking. Isn't that right? Right? How does this work? And do you know there is there's something called time constant? Have you heard what is time constant? What is time constant? What is time constant physiology? So time constant is the amount of time that it takes to fill or empty the lung by 33%. You understand? By 63%. So you understand? By 63%. So how much time it takes for the gas to go in and come out or come out, either go in or come out, 63% निकलता है, उसको टाइम कांस्टेंट बोलते हैं. समझ में आ रहा है? हाँ? 63% of the gas निकलता है, उसको टाइम कांस्टेंट बोलते हैं हम लोग. Okay? So you are understanding? Clear on this? Issue is what is happening is, and why you have to give this high tidal volume. I'm explaining to you that only. Why this high tidal volume should come in is actually dependent on time constant also. Let me explain to you how this is very interesting actually. So you understood the concept of time constant? Time constant is if I have a lung, okay, how much of time it takes for this to come or empty out by 63%. So say it empties out 63% in 3 seconds. That's your time constant. समझ में आ रहा है? हाँ? Okay. Asthmatic lung is full of lot of short time constants because it's small. They are non-compliant. They are small. Are you understanding? So the time constants are very small. समझ में आ रहा है? हाँ? If normal lung takes 3 seconds, the asthmatic lung may take 1 second. It may take 1 second. It may be very, very low time constants. So it's very, very low time constants and you give very low tidal volumes. Very low tidal volumes. Where it will go? It will actually go to that area where the time constants are large and it will cause hyperinflation and other problems. That's why I want to give larger tidal volumes so that quickly it goes into these areas and causes homogenization. Are you understanding? it goes into those areas very quickly, so that it homogenizes the lung. That's why I want a slightly high tidal volume. I can't give slow tidal volume. That is also the reason that I want to have a volume control mode of ventilation, because what happens is that's a square waveform. The square waveform ensures that there is homogenization of the lungs. It gets all of the lungs together in such a way that the air is distributed evenly. This is what the entire thing is. Now, this I ratio, now let me give you an example, okay? Your I ratio, you're going to change from 1:3, from 1:2 to 1:3 or 1:4. Let us make it this way. Versus, you're going to change your RR from 16 to 10. Which is more better? Our question is, we have an expiratory airflow limitation which we are having in this patient. We are having expiratory airflow limitation. If I am given an option that I want to do something, so that the expiratory airflow limitation comes when carbon dioxide gets washed out. This is our thinking, right? We want the carbon dioxide to get, because it's accumulating. So what do I do? Do I do this or do I do this?
Sir, decreasing to 10 will be more beneficial, because in that if we keep I ratio 1:2, or then the time required which we get for expiration will be more.
Is much higher than if you keep it at 16 and convert this. So don't concentrate on I. This is what I'm trying to tell you. There is no point of concentrating on I unless you are giving more than 10 liters per minute of minute ventilation. Unless you are giving more than 10 liters per minute of minute ventilation, there is no point of looking at I ratio. Are you understanding? Don't try to fiddle around with that. Get the RR down. Are you understanding what I am saying? समझ में आ रहा है मैं क्या बोल रहा हूँ? When the RR goes down, the expiratory time will automatically become very, very high, rather than you creating an I ratio that is different. You are understanding, no? So if a patient is an expiratory airflow limitation, I will probably increase my tidal volume and reduce my RR. I will increase my tidal volume and reduce my RR as much as possible, because when I reduce my RR, my expiratory time is actually increasing compared to when I do my change in I ratio. समझ में आ रहा है?
Time constant plays a role
in this, in the RR. Okay, that's why the time constant is working. Okay, you understand, na? That's why the concept is, if the patient goes into expiratory airflow limitation, reduce my RR and see what's happening. Clear? So here, so that would be my, so I'm not really going to concentrate on my I ratio as much. I'll keep it as 1:3 only, whatever it is. But if I have expiratory airflow limitation, I'll reduce my RR to 10 and 11. So the right settings on RR initially would be 10, 12 or something like that. The right settings would be 10, 12. The answer is, look at your saturation. Look at your ABG. Okay, if your ABG is showing that the patient's PCO2 is 22 or 21, you know, your ETCO2 should be 28, 29 or 24, 25. Don't try to increase the PCO2 further. You understand? Keep it at that 24. As I told you, we are only maintaining. We are not doing anything specific. So, but I would start at a slightly higher tidal volume, at an I ratio that is 1:3 maybe, and an RR that is very low, maybe 12, maybe 10, and I look at my expiratory airflow limitation. This is also the time when I am looking at my plateau pressures. This is also the time when I am looking at plateau pressures. Why do I want to look at my plateau pressures? I want to look at my plateau pressures because in the event that I am giving some peak and my plateau pressure goes up, what am I doing? What am I doing? If I increase my PEEP and my plateau pressure goes up, what is my PEEP setting here? I can keep it 0 also. Why I can keep it 0 also? Because there is an auto PEEP that is there. I don't need the PEEP per se. In the event I start PEEP and my plateau pressure goes up, means what is happening? The alveolar pressure is going up, you are creating more auto PEEP. Okay, but in the event that I increase my PEEP and my plateau pressure is not going up, that means my PEEP is actually opening up those alveoli slowly that will collapse and my bronchial bronchodilators have started working. You see how I am getting information from the ventilator? From the ventilator I am getting this information what's happening. What do I do? I actually saw my plateau pressure. I saw it's 20, say it's 30, whatever it is, 30 plateau pressure. Okay, here it's very important to set your alarms right. Okay, your peak pressure will be 50, 48, 49, that will be, your alarms will start ringing because it is set as per ideal body weight. So you have to keep your alarms 48 अगर है तो 52 पे रखो alarm को, 4 से ऊपर रख दो, क्योंकि ऊपर गया तो you know you're doing something wrong. You're understanding? You're doing something wrong there. Okay, so this is also the time, this is the one of the few indications in critical care where you are paralyzing your patient and deeply sedating your patient. This is one of the few indications in intensive care where you are paralyzing and deeply sedating. Okay, here you want the RASS to be -3, -4 and -5. You don't want the patient to get up again. You understand? Because I want to keep him as down, as deep as possible. Right? The RASS will be -4, -5, and this patient will be as deep as possible and paralyzed. You understand? So the first, I have to be ready when I'm doing this. It has to be as deep as possible. -4, -5 RASS. Patient should not wake up and should be paralyzed. Clear on this? In the event that I add PEEP and my plateau pressure goes up, means I'm doing something wrong. My auto PEEP is increasing. How do I find the auto PEEP here? By doing end expiratory hold. When I do end expiratory hold, whatever pressure is lying inside my alveoli, that alveoli pressure is what is showing. That is called the intrinsic PEEP. But what you also do over here, is when you have your peak pressures like this, when you're having this, you can actually figure out how your airway resistance is changing. How do you do that? In your pressure curve, you can actually figure out whether airway resistance is improving, decreasing, whatever is happening. So what will be your curve here? Your curve will be like this. This will be your curve. This will be your curve. Your peak pressures will be high, your plateau pressures will be low. Okay? So how can you understand whether, so what is your airway resistance here? This drop is your airway resistance. You understand, no? What is happening over here? Why this is airway resistance? Why this is airway resistance? Because when you do an inspiratory hold, you are cutting off the resistance. What is left behind is only pressure. When you are doing an inspiratory hold, what is happening? The flow is stopping. Flow contributes to airway resistance. Flow contributes to airway resistance. You understanding? So when I am pressing inspiratory hold, I have stopped the flow. Since I have stopped the flow, what I am seeing is airway resistance. It's airway resistance. Okay. So if I have come from pressure to pressure, this is your ohmic resistance. This is your ohmic resistance. So as you are improving, as the patient is getting improved, this will become smaller. That resistance of the airways will become smaller. You are understanding? This was long, huh? This becomes smaller. You understand? This becomes smaller. So, understood this?
As well as peak inspiratory should not rise.
Sorry?
Peak inspiratory should not rise as well as. Plateau pressure should not rise.
Will not rise. What will happen is, say for example, you put PEEP. You put PEEP, this will go up. This thing will go up. So your resistance is not changing. You may want to give PEEP. I don't know what you want to give PEEP. You decide to give PEEP. Your PEEP will cause the plateau pressures to go up. It will cause it, no? Because it is going to add to the PEEP. At that time, this will remain that only unless you have treated it. So this is your resistance.
Sir, how much PEEP should we get started? Like,
So how much PEEP? So we have not even got into PEEP as of now. Okay, let us get into PEEP now. We want to show this much. Tidal volume, peak pressures, plateau pressures, what I'm looking at, pressure graph, what I'm looking at. At this moment, I also have to concentrate on my expiratory airflow limitation. That is my flow graph. In my flow graph, I have to concentrate to figure out when the patient is expiring, whether it is reaching the baseline. This is a pressure graph. There will be a flow graph also. The flow graph will actually tell me when I stop the flow, is going to negative, and then this has to reach the baseline. If it does not reach the baseline and goes from here and then goes up, what you're developing here is actually gas trapping. What you're developing here is gas trapping. It's auto PEEP. So what you're developing here is gas trapping. It's auto PEEP. Are you understanding? In the event that I already have auto PEEP, there is no reason for me to give PEEP. I don't want to give that PEEP. On a patient who's ventilated, मुझे फर्क नहीं पड़ने वाला है. Auto PEEP का problem कभी होएगा जब patient is on a NIV. We said dynamic hyperinflation, which causes positive end expiratory pressure. Intrinsic positive end expiratory pressure is a problem when the patient is breathing on their own. For example, this patient you convert from paralysis to normal breathing. you remove his paralysis, and he starts breathing on his own, then the problem is what? In order for him to move air and trigger the ventilator, he needs to breathe against that intrinsic positive airway pressure. समझ में आ रहा है? ये तुम्हारा airway है, ये तुम्हारा alveolus है. I need a pressure of normally -4. It moves the air down. It moves the air down. Now what I did? I put positive pressure and made this 4. I made this 4. Okay. Now what does he need to do? He first needs to make this 4 0. Then he has to make this -4. That means he has to make minus to move in air. He has to move -8 to move in air. So my problem of flow limitation, my problem of auto PEEP is a problem when the patient is on NIV or you're converting from paralysis to normal. You're understanding? You're understanding? Huh? So at that time, how do I set my PEEP? At that time, what do I do with my PEEP? That's the big question that comes in. First of all, before it goes into that situation, you should have already got this graph back to normal because your bronchodilators have not probably worked. It's not worked as well. But there are certain patients like COPD patients who do have auto PEEP. Even after giving bronchodilators, there are these combined asthma COPD patients where you just can't get that intrinsic PEEP out. So at that time, we normally say that we do the same thing. We start the PEEP and look at the plateau pressures. If the PEEP causes the plateau pressures to go up, that is clinically one of the times you'll tell, "Arey, this PEEP is not good enough. This PEEP is bad. I probably need to reduce my PEEP." Other way around, I can actually monitor my pressure, my graph here. Okay, find out my intrinsic peak by doing inspiratory hold and give 75% of that PEEP. And give 75% of that PEEP. समझ में आ रहा है? How does that work? It is counterintuitive, no? How does that work? You understood or didn't understand? Didn't understand it. Okay. So the question that Sachin asked was how much PEEP to give. So Sachin, are you clear with the fact that if the patient is having intrinsic PEEP, I don't need to give any PEEP?
No need to give.
You can leave it. जरूरत नहीं है. Patient अगर passive है तो मेरे को वैसे भी कुछ problem नहीं है. My problem is going to be with respect to heart-lung interactions at that time because of the fact that PEEP बढ़ता गया तो cardiac system down हो जाएगा. That I have to keep a watch. I am not that I have a problem. I will have a problem if my PEEP is too much. It is going to cause cardiopulmonary interaction and cause problems. You are understanding? But my major problem will come when the patient starts breathing on his own. My major problem will come, say, if the patient is in NIV. That is where my problem is. So now, normally how are we breathing? We have our mouth over here, airway pressure, mouth airway pressure. We have the trachea, whatever, tracheal bronchi, and here we have alveoli. Normally what is happening? -4. Patient breathes -4 and the air moves from top to down. Now what is happening is you have an intrinsic positive pressure that is developed, which is say 5. This is 5. So that means in order to move air from top to down, it has to first overcome this 5. It has to overcome this 5. So what it will do? It will first breathe -5, then it will breathe -4. So -5, -4, that is -9. When it does -9, air will move from the top to down. Simple. इतना समझा? इतना समझा? Now the issue is how do I make this patient more comfortable? So what I can do is I can negate this PEEP by making this 5 here 5. So my airway pressure, I'm going to make this 5 here. When I make this 5 और 5 तो 0 हो गया. It's going -4. समझ में आ रहा है? Are you understanding? So I'm going to keep my pressure of 5, and now he has to only take -4, the normal, in order to get it. So better to keep it 5. We say don't keep it 5. We say keep it 75% of the intrinsic PEEP. That is what is proven. So if it's 5, I'll keep it say 3. Do you understand? We keep it as 3, and then he'll be able to move in the air much better. You understand?
So this is IPAP.
Intrinsic PEEP.
EPAP.
No, EPAP is different. No,
EPAP
we are not come to that still now. IPAP and EPAP.
That is NIV.
Sorry.
So NIV में क्या है? Now say for example you have not put your patient on the ventilator. NIV में you have these are all terminologies. So IPAP is equal to your pressure support on your ventilator. EPAP is equal to your PEEP on the ventilator. On our ventilator sometimes it's called even ASB. Okay, there are different kind of ventilators that we have, so each of them show a different number. or different word. So pressure support, IPAP and EPAP. Okay, so if you have a patient of asthma and you want the patient to breathe well, you may have to increase the EPAP slowly to see how he is improving. You understand? So if you increase the EPAP, say 4, patient, then you make it 5, gets better. Means he is able to move in air. Why is he able to move in air? Because you balance the peaks of the intrinsic cavity, because otherwise you don't know how the intrinsic peak is. He's able to move gas because you are not giving it's not a bronchodilator working, it's just he's able to move his gas properly. Are you understanding? So I'll increase my EPAP slowly because that's my peak. That's the peak I want to add over here. You understand? And IPAP is only when the tidal volumes are very low. So if the patient is having a very low tidal volume or the patient is unable to move in any air, I will increase my IPAP, but EPAP is what I have to be concentrating on when it comes to bronchial asthma.
So in IV, it is neutralizing the...
Yes, yes. So you give that EPAP slowly so that it reduces the intrinsic peak inside, stents the airways, and at the same time causes the patient to breathe well. It stents the airways, gives that intrinsic peak, balance the intrinsic peak. So the quick question is, what is intrinsic peak in a patient who is actually not ventilated? Very difficult to find out, no? To find out that, it's very difficult to find. Otherwise you put an esophageal catheter and then you actually monitor, and that's how it is. But you can't do that. So clinically this is what you do. Clinically this is what you do if you have a patient on an IV. So that, okay, and then after you've gone through all these things, and still the patient is having a problem, which is very unlikely. It's very unlikely that the patient is having a problem still after doing all these things. Then you may want to try things that are not really evidence based, of which one is Heliox. It is not said that Heliox works better. It is not said. Okay, what is Heliox? 30 and 70, 30 and 70, 80 and 20. So 80 and 20, not 60 and 40. So 80 and 20 and 30 and 70, and that is the reason that if the FiO2 is more than 30, you can't use Heliox. If the FiO2 is more than 30%, say your patient is an FiO2 of 45%, you can't use also Heliox because of the fact that it can give maximum 30% FiO2. You are understanding? Heliox. Huh? Personally, I used it for a long time, it doesn't work. This is what even the guidelines now say. Heliox is not supposed to be proven, not really run of the mill routine. Okay, this is what we have also seen, and I was working with Heliox for a while when I was abroad. It's not working. Okay? So this is all about the exact opposite occurs when you are weaning off your patients. So these patients should be weaned off quickly. They should be weaned off quickly. Once their bronchitis effect is out, you weaning off this patient. That's how it is. Okay?